Hello, everybody. Let's see. I'm Serena Mateen. I will be introducing my distinguished panel in just a minute. We are welcoming those of you who are here in person, and also this is being live streamed. And so for those of you joining us electronically, virtually, welcome also. We are trying to make this interactive. After each case presentation, we probably should have time for one, maybe two questions. Please do come to the mic so that the folks who are joining us by live stream can hear the question as well. With that being said, there's going to be a QR code. Thank you. We're going to do a pretest. Polling, so if you want to scan this and be able to provide your answers. And we're going to move on. Okay, polling question number 1. Risk stratification to assess risk of upper tract urothelial cancer can be most optimally performed using which of these methods? A, AUA or EAU guidelines or clinical nomograms. B, ureteroscopic evaluation with staging biopsy. C, urinary cytology. D, computed tomography. You can start entering your answers now in the next 15 seconds. 10 seconds. Okay, 5 seconds to answer. Okay. Question number 2. A 70-year-old patient with high-risk, unfavorable UTUC has a preoperative GFR of 65 with a healthy-appearing contralateral kidney that has 50% differential function. The patient is diabetic with a 3-centimeter tumor. What is the patient's predicted post-nephroureterectomy GFR? A, less than 30. B, 30 to 35. C, 40 to 45. D, greater than 60. E, this cannot be calculated or predicted. You can start answering your questions now. 5 seconds. Okay. Oops. Thanks. I got it. Thank you. There we go. Question number 3. Which statement most accurately describes the role of perioperative systemic therapy for sporadic UTUC? The use of neoadjuvant cisplatin-based chemotherapy is not supported by prospective data. B, adjuvant cisplatin-based chemotherapy after nephroureterectomy has not been shown to improve survival outcomes. C, the use of intravesical chemotherapy after nephroureterectomy for prevention of bladder disease is supported by level 1 data. D, the use of neoadjuvant immunotherapy is supported by prospective data. Which is the most accurate description of perioperative systemic therapy? You can start answering the question now. Very good. We'll go to the next question. Number 4, you are seeing a patient with UTUC who is concerned about having Lynch syndrome. Which of these findings would support that possible diagnosis? A family history of lung and kidney cancer. B, prior history of sarcoma. C, prior history of bladder cancer. D, tumor immunohistochemistry showing positive PD-L1 staining. E, tumor immunohistochemistry showing absent staining of MSH2 protein. You may start answering now. 5 seconds. Oops, excuse me. Okay, number 5. A patient with high-risk, unfavorable UTUC receives initial chemotherapy with a radiographic complete response. Post-chemo nephroureterectomy is not indicated. Excuse me, this is going to be the most correct answer. Which of these is the most correct? Okay. So A is post-chemo nephroureterectomy is not indicated. B is initial cisplatin-based chemotherapy is indicated for patients with regional lymph node positive disease. C, A patient who underwent prior nephroureterectomy develops a lymph node metastasis in the ipsilateral hilum. Surgical resection is indicated. D, a patient with a small, high-risk, unfavorable UTUC and regional lymph node metastasis receives initial chemotherapy, but disease progresses to multiple other lymph nodes. Surgery is now the next curative option. You may start answering now. Ten seconds. Very good. Thank you. Jake, can you go to my next file? Great. Thank you so much. So I'm very happy to introduce to my left Dr. Suzanne Cole, who joins us from the University of Texas Southwestern. She is a superb medical oncologist, and I've had the privilege of being able to actually share some patients with her over the years as well. And then to her left is Dr. Adam Feldman from Massachusetts General Hospital, who also has a lot of experience with this disease, and we have had the opportunity to work together past several years on a variety of different projects. Welcome. Thank you, both of you, for joining in this course.
Thank you again.
So, okay. Thank you. These are our disclosures next, and they're available at the AUA site as well. The learning objectives for this course, we want to help identify clinically available data for risk stratification, talk about the importance of kidney function and recognizing it, the implications of it before surgery, and in terms of what our expectations are after surgery, looking at the clinical trial data on neoadjuvant and adjuvant chemotherapy, talk about inheritable syndromes in this disease, how do we identify them, and screen and diagnose, and even how to treat these. Talk about the role of intravesicular chemotherapy. This we'll touch on this a little bit through some of the courses. And then also talk about using response to preoperative chemotherapy in terms of making assessments for surgical management based on those responses. Next slide. So this will be mostly case presentations. We've been asked to minimize didactic slides so that we can show you good cases and a fair number of these. But you do have a syllabus available electronically, and that will have the references and didactics there, and roughly follows the topics will follow the sequence of the cases in rough fashion. And there will be, of course, some overlap between some of these cases. So we do have 9 of these case presentations here. We may not have time for all of them. Hopefully we'll get through the first 6 or 7. And then if there's we want to leave time for questions, and we can always pick one other additional case to do depending on how much time we have available. Okay, so the first case is a 72-year-old with a history of low-grade bladder cancer for many years. They're found to have recurrence at the left ureteral orifice and intramural ureter. This was non-invasive low-grade as well. There's no evidence of metastatic disease. CTU is negative. GFR is 55. Ureteroscopy is performed and shows multiple very small tumors throughout the distal ureter and the renal pelvis. Now, the largest is only about 5 millimeters, but there's many of these. Here's what a retrograde polygram looks like. They're so small you can't really see them. Biopsy confirms these are low grade. Washings are negative for high-grade disease. Now, these are all laser ablated at the time of the diagnostic ureteroscopy. And question is, what would you do next? Dr. Feldman?
Yeah, no, this is a great case, and I think I'll just make some comments about, I agree, you've got several papillary low-grade or several papillary tumors. I think definitely if you're efficient with what you're doing ureteroscopically, you can laser ablate them. I personally have transitioned to using the thulium laser. I think it's very efficient. I think it's very safe for the urothelium. And in this patient, then the question is, do you do surveillance or do you do some additional treatment? And if you're going to do surveillance, you really need to take a second look ureteroscopy. And that has been demonstrated. There's material, in your course materials, there's evidence to, show that it reduces the recurrence risk in doing a second look ureteroscopy. And then the question is, now that we have, UGN-101 or Jelmyto? Do you offer this patient a course of Jelmyto? So I think for this patient, I would certainly discuss it. I would offer that. And you need to, in anticipation of that, you need to plan ahead at the time of your uteroscopy. So you want to actually, I don't know if you want me to get into the nuances of that now, but you need to measure what the volume of the renal pelvis and calyces are, because that ends up determining your dose. So the total volume that you have for Jelmyto is 15 cc's, and so you want to be able to know, but you don't give all of it depending on the volume of the renal pelvis and calyces, and that's how you determine the volume of instillation each time.
So of those 4 options, you would give the patient the option of surveillance versus mitomycin hydrogel? Or would you strongly push for hydrogel treatment?
So if you look at the, based on the Olympus trial, there's about 50, I think it was 58% complete response. And then of those patients that had complete response, I think it was about 56% that had durable response at a year. Our updated data, so we have a multi-institutional cohort that we're looking at outcomes and in the real world setting. And there's about a 60% response of the people, and actually of people who respond initially, 68% are disease-free at 3 years. So you have a reasonable response rate or I should say durability response in people who respond initially. But you have to be open with patients about sort of what the course of that treatment will be.
Okay. All right.
It's
so
not
Suzanne, clearly no role for systemic chemotherapy here, but do you have an opinion on this anyway?
I never see these patients, so usually
Fair enough.
I just leave it to you guys.
No chemo, right?
No chemo.
But we all agree nephroureterectomy would be complete over-treatment, and dripping in chemo or BCG in this day and age it would not really be something one would be looking at, right? Unless for whatever reason you don't have the mitomycin hydrogel available.
Correct. That is an option. It is absolutely an option,
Okay.
but yeah.
Yeah, and so this is what we elected to recommend to the patient was the mitomycin hydrogel. As Dr. Feldman pointed out, you do want to do renal pelvis measurements. You can do it at whatever any time. If you think about it at the time of your uteroscopy and you think it's low grade and they may be a candidate, it's opportunistic to do it at that time. But you do there's so much variability in the renal pelvis volume, as you all know, that you do need to take that into account. Sometimes it's only 5 cc's. Sometimes you can use up the entire 15 cc's of the formulation that's given. In this particular case, it was about 10 mLs of volume that we calculated. Mitomycin is an extremely finicky compound, and for you to optimize it, the patient needs to be dehydrated for each treatment, and they also need to be alkalinized. So that does require some of that preparation for the patient. Now, some of us are doing many of these with nephrostomy tube installations. And for those of us that do that, we do the first one under fluoroscopy just to make sure that the tube is in good position and that there's no extravasation, and just as an extra safety step. Having done many of these now, I'm not sure that I need to keep doing them, but basically also have a low threshold to do an imaging study if you have any concerns or if they complained about it getting pulled on or anything like that. But otherwise, if everything is going as predicted, we just do it once. And then it's much easier to give because you just do it in the office. You don't need fluoroscopy or anything. They come into the office as long as they've had no issues with the tube. We do take some safety precautions, but otherwise we just inject it and they're done and they go home. So now one of the limitations of adoption of this particular treatment has been the concern for ureteral stricture formation. And in the published studies, it's somewhere between 30 and 40%. And there is really no great data in terms of how we prevent these, but basically based on a group of us who have been very involved with the clinical trial and managing patients, these are some of the mitigation strategies that we've developed. Using steroids, potentially, because it does seem to be an initial edema and inflammatory reaction that, if not recognized, can turn into bad scar tissue. Just taking a treatment holiday. It's low-grade disease. There's no particular rush to treatment. And so the one thing that we've learned the hard way is that it's okay to take a break. Give the patient a break for 2 or 3 weeks. If there's any suggestion that you have any narrowing, let the edema and the inflammation die down, and then restart treatment. Some people feel strongly about stenting every patient, or stenting if there's a hint of narrowing, and again, there's some variability there. The other thing that I started thinking about is maybe we should think about giving limited doses. So in a case like the case we just presented, if you've gotten rid of all the disease, you're not trying to chemoablate additional tissue, but maybe get rid of any residual microscopic disease or prevent implantation to reduce recurrences, then maybe we can just give limited doses and reduce the risk of stricture formation. Whereas if there is residual tumor and we do want the chemoablation effect, then we'll put a nephrostomy tube in and give it antegrade because the data suggests that the stricture rate is less. There's no good data for all of this. We do have some data for nephrostomy tube installations, but it's all retrospective. But this is based on essentially expert opinion. Adam, I think you had some comments you wanted to make about this.
Yeah,
right?
I'll make some comments. A couple of things. One, I totally agree with you about, in the adjuvant setting, trying to reduce the number of doses. I know you've been giving 3, and I think it's an excellent idea because and I agree, between third and fourth, that's around the time when, you can see that there may be some narrowing. I do a fair amount of retrograde delivery in the office. We have fluoro in our office, and I discuss, with patients the options and talk to them about the option of having nephrostomy tube versus the option of doing it retrograde. It's easier to give it antegrade. There's no question. It's easier on us as providers, and I still do an antegrade nephrostogram to confirm that it's in the correct position. But when you're using the delivery catheter, which is I think about 7 French, yep. you can, if you notice that there's any resistance in passing that, and you have to be gentle, when you're passing these catheters and wires. But if you notice there's any resistance, that's where you stop. You don't give it. You take a break, and then. Maybe put them on a steroid debate. There's loose evidence for the steroid pack, but and in where that comes from is from really the urethral stricture literature, but I think it's worthwhile.
So do you find yourself doing a lot of the retrograde because patients are saying, no way, I'm not doing
They don't want a nephrostomy tube.
And you feel like really strongly they should have
So
it?
I think amongst our group, there's some, I think, who have said, there's no question antegrade's easier. It's easier for clinic flow. It's easier for everything. It's a lot easier. And especially if you don't have fluoroscopy in your office, then you have to do that, right? So, and it's very reasonable if you don't have fluoroscopy in your office to, inject and aspirate, and if it flushes easily, then it's in the collecting system. I know you have a case where it wasn't in the collecting system, and you have to be very careful about that. Yeah. Because it's mitomycin, and we, as urologists, have a long history of knowing how mitomycin, the people who have a little more gray hair, of how mitomycin and the effects it can have in the bladder, it can have the same exact effects in the upper tract.
Perfect.
Yep. Thank
you. Excellent. Yeah, so in this case, we gave it as adjuvant intent for 3 weekly doses. You see here on the retrograde pyelogram, the hydrogel itself is radiolucent. You don't see it, but basically what most of us do, I think, is we inject contrast, first of all, to make sure we're in the correct anatomy, if we're giving it retrograde, and then essentially you can see the hydrogel displacing the contrast. One thing that's interesting is that when you give it through a ureteral catheter, it does start gelling because it's a narrow, long tube, and as it warms up, it quickly thickens. And so usually what you see is what you kind of see here, which is that doesn't perfectly flow into all of the calyces like a full liquid because it's thickened, and sometimes you even see it as like a spaghetti ball, I call it. Whereas when we give it as a nephrostomy tube, because it's larger diameter and multiple side holes, in those cases you do see it kind of flowing into things a little bit more easily. Whether that makes a difference or not, who knows, but that's been an observation.
The other nuance I'll make is you measure, the dose is what you measure, right? Previously when they're asleep. The volume, the volume. But, especially when I give it retrograde, I actually pay a lot of attention to the patient. Because if they tell you they're feeling discomfort or pressure, you stop and you may decrease the dose.
Yeah, exactly.
So, yep.
Good point. Very good point. So in this particular case, we gave those 3 doses of the mitomycin hydrogel, repeated the ureteroscopy 6 weeks later, and this was negative. The CTU at 3 months was negative, but had 2 new bladder tumors, and so we did a TURBT, and then opportunistically at that time took a look up just to confirm there wasn't any disease, and there wasn't, and the patient got intravesicular chemotherapy. What I do want to highlight here is that you can't rely on this mitomycin hydrogel to treat or prevent bladder disease. It dissolves over a slow period of time, and as we've talked about with mitomycin, it's extremely finicky. The minute it gets diluted, it's essentially ineffective. And that's essentially what the bladder sees, is a very diluted amount. And of course, the patient is also voiding during this time, so who knows how much the bladder is releasing. You can't rely on it. For a patient who's got coexistent bladder disease, they need definitive separate bladder treatment. Would you agree?
It's very easy to get fooled and think you can get a twofer, but you won't get it.
You won't get a twofer, right?
Yeah.
Very good. Do we have any questions about that case before we move on? Anything from the live stream, Adam? Do you want to check real quick? I'm sorry, can you speak up just a little bit?
The question is really... I'll let him in. While we're waiting for that mic, I might answer the question. There's a question in the chat,
Please.
which I think is a great question. So the question is, hi, so for distal ureter TCC, urothelial cancer, do you want the gel in the distal ureter and not the renal pelvis? I'm going to make a comment. I'm curious to hear what Serena says. So if you have a solitary distal ureteral low-grade urothelial cancer and you have nothing above that, I actually would favor a distal ureterectomy rather than put the entire ureter at risk for stricture. I don't know if you agree, but I just think those patients should have a surgical excision and reimplant. They do so well. And that's my bias.
I think it's wise, especially if it's circumferential. They're very high risk for stricture. You know, and what I have done in the past is done like a partial laser ablation, like half circumferentially, and then you could rely on gelmito, but we don't have good data for ureteral disease there,
I guess
right?
I would say if it's small and you can easily endoscopically treat it, that's one thing.
Right.
But if it's a reasonably sized tumor and you're going to depend on gelmito, then you're going to give gelmito and put the entire ureter at risk for something that's so low. Just do it.
You wouldn't inject it into the ureter itself, though, correct?
No.
Exactly.
No,
I would not either.
I actually, I mean, I've never tried it, and I
Right.
don't want to because I think it would cause obstruction.
So it has in the early days when before the clinical trial, in Israel, there is a case where that was done and it got rid of the tumor, but the patient developed a horrible long stricture as a result.
Yeah.
It's not published, but I know this from conversations with the investigator, Nir Kleinman actually, who was there and who talks about it if you ask him about it. Did we fix the mic? Yes. Great. Please go ahead, sir.
My question was related, really. It was just, it was about, given what you said about it being ineffective once the gel kind of warms up and dissolves, I assume we're not really, when we're instilling the gel via a nephrostomy tube or via a ureteral catheter, that you're really not getting any treatment to the ureter doing it that way.
So you are actually, and I think that was just that was the question, and so we have seen that tumor in the ureter will get effectively treated, and we've got data from that's published, and I can anecdotally tell you. I mean, you can, where I think you have a little loss is right in the tunnel, where you can still see some residual tumor, but we've definitely seen effective treatment and downsizing with in the ureter.
Very good. Let's move on to the next three cases, actually. All of these cases have something in common, which is that they're high-grade disease and a patient who shows up with good kidney function. But the point here is to show the variability of both the kidney function implications and as well the variability of high-grade disease. Okay, so for this first case, a 71-year-old female that has a 2-centimeter left upper pole tumor, actually found incidentally because she had a remote history of lymphoma and undergoes annual surveillance. And there's no evidence of any lymphoma that has recurred at all, but there's this renal pelvic mass on the left side. There's no evidence of metastatic disease. Ureteroscopic biopsy shows high-grade T1 disease. GFR is 62. She's a touch anemic. Nuclear renogram shows 49% function on that side. Performance status is okay, just age and comorbidity-related PS of 1. So based on this data, Dr. Cole, what would you offer?
So at our institution, we tend to lean towards offering people with good kidney function, high-grade disease, upfront neoadjuvant chemotherapy because the biopsies can be understaging people. We also have a clinical trial open that we're always thinking about for our patients, which is looking at MVAC with or without durvalumab, so an immunotherapy with chemotherapy in the neoadjuvant setting. And so we tend to lean heavily towards chemotherapy.
Okay. Adam, agree, disagree?
Yeah, well, I think you're going to show that. I mean, you have to think about this patient and what's their. If you were to do a so first of all, I think the patient needs a nephroureterectomy. I just want to be clear. High grade T1 disease, even if you, the patient needs a nephroureterectomy, it's at least T1 and maybe understage. So then the question is, what's the post-NU GFR going to be? And if that's going to result in a GFR that the patient is then cisplatin ineligible, then I think that is the ideal patient that should be considering neoadjuvant chemotherapy.
Perfect. And that's really what we want to start highlighting. And the AUA guidelines don't explicitly go in, well, they do explicitly go into it in terms of the idea that we should start thinking about what the kidney function is going to be before we create a new kidney function baseline. Yeah. So don't wait until after nephroureterectomy to think about it. Think about it at presentation. And there are ways of estimating this, and they're available in your syllabus. But you could do a very basic calculation of splitting the GFR in half, although that doesn't tell you how much that other side may have compensatory changes. So based on that, maybe it's between 30 and 40. There are nomograms available. There's RCC nomograms. We recently published a specific upper tract urothelial cancer nomogram as well. Based on those, her GFR would be 45. And this will have an impact on the patient's ability to receive cisplatin chemotherapy. There are some centers that maybe would give it to a level of 50, 55, but for most places are not going to give cisplatin below 55, 60. Would you agree?
So the POUT trial actually required patients who had a GFR of 50 or better, they had to go on the cisplatin arm. And so once that was published, I became much more open and aggressive, and sometimes I will also go a little below that depending on the patient. I do a lot of splitting the dose.
You can split dose or reduce dose, correct?
Yeah,
so there's other ways of managing it.
Our medical oncologist will go to about 50.
Right.
And I'll just comment that, depending on who who's part of your multidisciplinary team, there are times you may need to push them to give neoadjuvant in a situation like this.
Right.
I mean, that.
So there's two factors here. One is the kidney function, which we talked about, but the other is what is the risk of disease? Are we overtreating? Are we undertreating? And so I don't have this here, but according to the new AUA guidelines, this patient would have high-risk favorable disease. That data doesn't come with any objective values for you to guide yourself. All you know is that it's not unfavorable. And we've talked about the T1 staging potentially being understaged. And imaging, as you know, can also understage this disease, right? And so imaging is really more of a rule-in. It can confirm sometimes locally advanced disease, but it doesn't really rule it out, right? And so this is why we've developed risk stratification tools. And there's a variety of these available. I'm going to show you two of them. This one predicts T3 disease or higher. The accuracy is actually pretty reasonable for a clinical calculator, 82%. Very simple to use. In this case, the patient meets high-risk criteria. And then this one is on the basis of recurrence-free probability if they have a nephrou for high-grade disease. And in this case, it's not quite as clear because it's roughly, 60% chance of T3 disease, and the recurrence-free probability at 2 and 5 years is 82 to 70%. So you could argue that's more intermediate, not really high risk. And so, but either way, what we know is that if we do initial surgery, patient is not likely to get high, really good levels of curative chemotherapy. And so you need to have an honest conversation with the patient in terms of these are the risks and benefits. And the patient, given this data, is elected to proceed with neoadjuvant chemo.
And so I'll just make one quick comment. I know it's not your center, it's not my center, but if you go to cancernomograms.com, you can just plug the numbers in, and it'll provide it for you.
That's
so you don't
perfect,
need to use the little,
Yeah, exactly. You don't need to do that. Yeah, and I'm a big fan. I can't remember if we got these on the Fox Chase. I go to the Fox Chase one.
It is the Fox Chase.
It is awesome.
Yeah, that's cancernomograms.com.
Yeah, so you don't have to do these manually.
Yep.
So the patient received 4 cycles of GemCis without difficulty. They underwent a robotic nephroureterectomy with lymphadenectomy. Just as a side note, Adam, would you have done a lymph node dissection in this case?
I would have. It's high-grade disease.
Okay.
It's very informative.
Very good. And so obviously we don't really know what the stage was. We know it was at least a T1. So by all accounts here, given the post-treatment pathologic stage, she was downstage. And generally this is considered effective response. And as we can see, the GFR is a little lower than we predicted, and more than likely that's a result of some cisplatin nephrotoxicity that occurred.
And I might just comment, this might be a good, and tell me if I'm wrong, to comment on the intravesicular gemcitabine.
Yeah, please.
I mean, I think that's important, and there are different, There are different ways to do it. It's been shown to reduce the risk of bladder recurrence distally. Some historically, when people started doing, they were giving it at around 48 hours. Some were giving it doing it at the time of catheter removal, but we're giving it actually in the operating room. I think it's the same way you do it. Instill 2 grams of gemcitabine into the bladder, clamp the catheter. Once the hilum is once the artery is divided and ligated, then put a clip on the ureter, and then allow the gemcitabine to drain out, and then run a continuous bladder irrigation to irrigate the bladder. And we've had no issues with that. And
Exactly,
it's worked, yeah.
because also when the patient leaves the hospital, you're done.
Correct.
Right? You don't have
It's
to
much
follow
easier.
up. We actually don't even, do a cystogram in the hospital and take the catheter out before they leave.
And to me, it actually makes more sense, because that's when the cells are floating,
Exactly.
and that's when you want to kill them. So
I totally agree.
Yeah.
The only other thing I will add to that is I ask anesthesia to minimize fluids, because you are clamping the
Yeah.
bladder, for up to an hour and a half to 2 hours. So we definitely, don't want them to dilute the chemo or to get over distended. Is there any questions about that case before we move on?
And I'll just comment, use the chat to ask questions. I think that's the best way if you're going to do it through your phone.
How are you
Through the
staging this patient? Are you using PET scan, and would that change your decision to do a lymphadenectomy?
We don't use PET routinely in urothelial. I don't know if you do. We use conventional I+ imaging.
I hate PET scans. The resolution of a PET is not as good as a standard CT, number one. Number two, I think there are indications for it, and generally when I've used it is when they can't get a contrasted CT, and we have concerns about an MRI, for whatever reason, like they have a pacemaker and we can't get an MRI either. So for me, it's a very narrow indication for a PET. Sometimes post-surgery I'll do it because they meet those indications. I don't know. Do you have any thoughts about that?
I do a PET on almost all of my patients that are metastatic, because we find much more disease, or if you're thinking they're kind of at the border of being operable versus locally advanced, it's very informative if you find a high lymph node in their supraclav that's not palpable or super visible on the CT. So it's been very informative in the metastatic setting for us. We use a lot of MRIs and other modalities in the early stage, and these patients usually don't belong to me until they've been worked up. So the early stage is kind of your ball game.
I think potentially another situation would be an enlarged lymph node that you can't biopsy for whatever reason, and you just need some information as to guide treatment. Trying to think if I've been in that situation, but otherwise I don't. It doesn't help you with local staging at all, right?
Yeah.
We agree. But potentially for ruling in or ruling out metastatic disease, maybe.
But I agree that the CT on a PET is suboptimal.
The resolution, there's no question, it's not as good. Yeah. Okay, so going on to the second scenario of this. This is a 79-year-old male who developed hematuria, has a history of prostate cancer and proton therapy. That's really not a concern at this point. Has several comorbidities. Kidney function is actually pretty good, a little bit anemic, a good performance status. Ureteroscopic evaluation that was done based on findings on the CT urogram there shows a 2.5 centimeter papillary tumor in the right renal pelvis. Biopsy is high grade. Washings are rare atypical. And at the time, it looked like it was possibly endoscopically manageable. Of course, we didn't have the biopsy results, but just opportunistically, just laser ablated most of it, but there's definitely tumor left over. So based on that information, Dr. Feldman, what would you offer?
Well, it's high grade. He has a GFR of 80, and then the question again is, what do we think his GFR post nephroureterectomy will be? And I'd have to put in the numbers in the nomogram, and if we think he's cisplatin eligible post NU, it's reasonable to go ahead with a NU with regional node dissection, and so yeah, that. I think it depends on what we really think his GFR is going to be.
Good. And Suzanne, you were saying based on what you guys do, they would clinical trial or neoadjuvant chemo off trial.
Yeah, and this guy has more comorbidities. He has diabetes, and even though he's starting with a GFR of 80, it might really be 30 after surgery. And so then that takes cisplatin totally off the table.
Okay. Afterward, you mean?
After. Yeah.
Okay.
If
So
he doesn't get
neoadjuvant,
it
you
up
would be,
front.
okay.
Yeah.
Right.
So
And that's an important point. He does have right.
Right.
I would offer.
So based in terms of tumor risk assessment, by AUA criteria, it's a high risk favorable. EAU, it's high risk. They just have sort of a general broad bucket there, just based on the high grade. If we use the nomograms, the prediction of T2 or higher disease is 18%. developed by Dr. Petros, who just walked in. Perfect timing. T3 disease or higher prediction is 30%, and the recurrence-free probability is 87% at 2 years and 80% at 5 years. So actually it's high grade, but these predictions are not what you would think for traditional high grade. Like that actually looks pretty reasonable. And in terms of predicting the patient's GFR, yes, it would be below a threshold where we would comfortably give, would not comfortably be able to give cisplatin. But again, the risk stratification here looked much more favorable than we thought it did. And in this particular case, after discussing it with the patient, they were willing to forego initial chemotherapy based on this data and understanding, the risks of that. And so we offered surgery initially, and the patient underwent robotic nephroureterectomy with bladder cuff and lymph node dissection and intravesicular gemcitabine at the time of surgery. And pathology showed the residual tumor, non-invasive, high grade, and with a new baseline close to what we predicted of 41 to 44. But this is not to say that giving neoadjuvant chemotherapy would have been wrong. As you see, there's a difference of opinion in this case. But I think the important thing in these situations is the patient needs to understand that there may not really be a dogmatic approach, and they, in some ways, really have to be involved in choosing their poison, if you will.
Well, and I'll just add that let's say that the path was not favorable. Maybe it came back, he didn't get neoadjuvant, and it was a T3 or some surprise, more advanced disease, a surprise lymph node. Those things happen. And we do have the POUT trial data to where if you did not receive neoadjuvant chemotherapy, we can give you carbo-gem. If your GFR is not adequate, if you're not at 50, we could definitely do that. And then there's also adjuvant nivolumab as an option for patients that you're really worried are high risk and going to have recurrence.
So would you rather give, knowing that, carbo-gem or nivolumab? I mean, it was interesting when the POUT trial came out and when it was presented, initially it seemed that carbo was okay, but it wasn't until it was finally published that it seemed in line with what we know about, carbo versus cisplatin. So would you...
The survival was not...
It was not equivalent to cisplatin, correct?
Not as good.
Yeah,
just to be
correct.
clear.
Yeah, I mean, we know that carbo is not the best drug, and so,
Right.
but it's better than zero.
Right.
And if you look at the progression-free survival differences, if you got a POUT regimen or if you got adjuvant nivolumab, they went from about 40% disease-free survival to 70% in both trials, and so they're pretty equivalent. I think you need to choose which might be the best option for the patient based on their comorbidities. Nivolumab has a whole different side effect profile. It also goes on for a year, and that's a long time to commit to, whereas carbo-gem, we're done very quickly.
Yeah.
Yeah.
Good point.
Yeah.
Very good point. Any questions about that case before we move on? Okay, very good.
Oh, there was
Yeah,
there's one question.
Okay.
Are there trials ongoing assessing EV Pembro for upper tract urothelial cancer, both in the neoadjuvant, adjuvant, and metastatic settings?
Not yet, but I just came back from ECOG, and these things are on everybody's minds. EV Pembro will very likely be moving into the front line because it's so effective for the metastatic setting, and so I think it's coming.
Perfect question. Great. Thank you.
Great timing.
Awesome. Let's go to the next case. So final situation with high-grade upper tract cancer with good kidney function. 53-year-old with gross hematuria, left flank pain, very good performance status, very good kidney function, no anemia. CT shows a bulky left renal pelvis tumor. There's no evidence of invasion. There's no lymphadenopathy, no metastatic disease. Ureteroscopy shows a large papillary tumor filling the renal pelvis. It's mostly seen floating around, but we couldn't really see the base of it because it was so big. Biopsy was done showing high grade, and the washings are suspicious for high grade. Here's the CT
Can I ask
and
you
an
a question?
endoscopic picture. Yes.
So if you have a huge tumor that's got like a small pedicle floating around, does that predict that it's not as dangerous? Okay, so...
Adam, what do you think?
Yeah, I mean, I have recently, within the past several months, managed a patient that had this large ureteral tumor, and it was on a little stalk, and we were able to just laser the stalk and pull it right out. And it was a really neat case, but...
So at most,
but
in that case, it'll be a T1,
Yeah.
right, with the laminopropria invasion. For it to be a T2, it would have to invade through the stalk and go into the muscle, in which case it's not going to be a skinny stalk.
Yeah,
you know?
exactly. Yeah.
So yeah, I think that and the architecture is strongly predictive. I'm not sure we've ever got granular as saying, you know, papillary on a stalk versus just papillary versus, you know, I do because I'm
But
interested.
the fact that it's floating is different than like a super infiltrative.
Absolutely. Sessile,
Everything.
for sure. Sessile and papillary are highly predictive variables. And in this case, we didn't see the base. We didn't know if it was a broad base, you know, or a narrow pedicle or anything. But, you know, it's a huge tumor, right?
So this, and it's interesting. Obviously, we don't have all the cuts of the imaging, but, you know, if you pay attention in your scans to the, particularly the I plus CT, you can actually, if you look for any little stranding around, you know, in the fat around the tumor, around the renal pelvis, you can get some sense of, do you have any risk of invasion? Again, it's hard because this is one slice.
Right.
But you pay attention to the way.
And just because they don't mention it, it's not, the
No.
radiologist may not be, you know, they may not understand the staging or the disease much, especially if it's somewhere where they're not seeing a lot of this, right?
We're better
even
at those
our center where we
nuances.
see tons, I don't necessarily get comments about it. I have to look at every single image and make that determination. If I have a question, then I go back to them and be like, hey, by the way, take a look at this, you know, in a respectful way. Not saying that they missed it, but be like, can you, like, what do you think? And sometimes they'll be like, oh yeah, that looks concerning, and sometimes they'll be
Yeah.
like, oh no, that's just edema or something.
Yeah.
So, so in this particular case, again, high risk in the EAU, high risk favorable in the AUA. Risk for T2 disease are higher, 30%. Risk for T3 disease is 20%. And again, the recurrence-free probability prediction also is really quite good. And the prediction for kidney function afterward is actually pretty good too. Dr. Cole, would you be comfortable giving this patient adjuvant cisplatin if we were totally wrong about these predictions?
Yeah, I would be comfortable with that. But I also, just one thing that always kind of sits with me is this guy is super young. He's only 53 years old. He might live another 4 decades. And so although these nomograms are predicting that he's unlikely to relapse or unlikely to have metastatic disease, there is a possibility of that. And
Yes.
so I just have a hard time walking away when somebody's super healthy when we have a curative option for them, not offering it up front.
Okay, yeah, so you want to make them feel older a little bit more quickly.
I want
With
them-
chemo,
I
you
want-
mean? With
hey,
chemo?
You have to be alive to be older or to
Good
feel
point.
that way.
Very good, very good. No, and that's a very good point, and you know, it is a consideration there.
But-
So, in this particular case, quite honestly, there was a big disagreement between the urologist and the medical oncologist. Was not Dr. Cole. We had our differences of opinion, and we both felt pretty strongly about our opinions in this regard. I thought it would be gross overtreatment because I had some somewhat objective data. And on the other hand, the medical oncologist's opinion was that the risk of overtreatment was worth it. Perhaps they were thinking along the same concepts that Dr. Cole was thinking about. And again, it's difficult to be dogmatic when we're looking into a bit of a informational void. And this case, quite honestly, is a situation where I put the patient in the middle. Usually we don't want to do that, right? Usually we want to decide as a team and present a united front. But the patient needed to be aware of what the risks and benefits were here because we each thought that our opinion was the one that had the stronger stance. And anyway, the patient was given the options and elected to undergo initial surgery. Yes.
And you were right.
But I'll just comment. No, I mean, I
Of
think.
course, I'm not going to show the cases where I was wrong.
I'll just
Yeah.
comment. He had a GFR of 100,
Yeah.
right? His predicted GFR was still cisplatin eligible. I actually would have handled it the same exact way. I would have definitely had a consultation for consideration of neoadjuvant chemo, but my bias would have been to go forward with surgery up front.
Right.
Yeah.
And so again, these cases show the variability of the disease, but also how the kidney function can be variable but has big implications for how you might want to think through strategizing treatment.
And notice the size of the mass, and it was still just T1.
Exactly.
Right?
Yes. And so you'll notice the AUA guidelines do not have size criteria in them because we recognize, number one, there's limitations in measurement for one thing, and a lot of the studies that have been done, when you actually include all important variables, size falls out because there's cases like this
The only thing I think you need to pay attention to, and we're not there anymore because we're past the low-grade disease, is large low-grade tumors. So large low-grade tumors have greater than 2 centimeters, have a higher risk of actually being undergraded. So you have to be careful.
I don't disagree. And it
Yeah.
has endoscopic implications for endoscopic management as well. So it's not that it's not important,
Yeah.
but for risk stratifications, it just may have less importance than some of these other variables that we look at. Great point. I'm going to go on to the next case unless there's like a burning question from someone. Please, Dr. Petros.
So with this tumor, right, heterogeneous, right? Mostly low grade, there's areas of high grade. So you are not concerned, not giving him neoadjuvant cisplatin combination, that he could develop later metastatic disease being heterogeneous?
So-
has foci of high grade disease and then high grade T1, which is invasion, right?
I think we all have those patients where, you know, they are supposedly not muscle invasive, supposedly no potential to have metastatic disease. They only had low-grade disease or T1, TA, and then they're metastatic, and it's kind of like, what happened? You know, those people are in my practice. But when you do get like a pathologic, you know, a patient who is untouched by chemotherapy, pathologic TA, T1, you cannot justify any kind of adjuvant chemotherapy or immunotherapy because of the risks and toxicity and expense.
Yeah, you're gonna. I've had the same low-grade, disease. Low-grade disease responded to endoscopic management, metastatic disease.
Yeah, we've
Frustrates.
had
Very,
we have
very
those
frustrating.
But you can't treat every patient like a zebra.
Right.
Correct.
And so that's one thing we have to be careful about.
Correct.
Let's move on, and this here we're going to highlight the role of adjuvant therapy. Now, this is a unique case. For those of you who may have attended previously, you're going to be like, oh my God, this case again. But I really like this case because it highlights several sort of traps that we can fall into.
Can I? There was one question.
Oh,
Sorry,
please,
I missed
yeah.
it. So
Mhm.
I just noticed it. Do you ever use MRI in this setting, similar to its use in bladder, in assessing for T2 disease? I'll just say, I don't think it's so subtle. I don't think that we're going to be able to really see microscopic invasion, T2 invasion with MRI. I don't think it's going to be any different.
Completely agree. The resolution isn't there for that. You can't see the muscle. You can barely see the ureter sometimes on the MRI. So to move on, in this case, it's a 66-year-old patient who underwent laparoscopic nephrectomy elsewhere for what was suspected to be a renal cell carcinoma. These show the pre-surgical images. If you don't think that it's a very central tumor, you might think that it's an RCC that's just invading into the sinus. But pathology showed actually a T4N1 high-grade urothelial cancer. There were no ureteral tumors in the specimen, and the ureteral margin itself was negative, but of course it was a nephrectomy with a residual ureteral stump. Yes, Dr. Feldman?
I'm going to make one quick comment, because if you can go back to the imaging, and I know this wasn't, you had not done the nephrectomy, and I'll just make a comment that these renal masses that you wonder, is it urothelial? Is it renal cell carcinoma? This is the perfect case for a percutaneous needle biopsy. And the reason is because if it's an invasive, clearly invasive on imaging urothelial cancer, that patient should be getting neoadjuvant chemotherapy, right? So this is we talk about renal mass biopsy and small renal masses. This is the perfect case for that. And
I don't disagree at all.
Yeah.
And I think that, for upper tract cancer, there is some role for percutaneous biopsy, like a post-cystectomy case. Or it's actually the one diagnostic modality we have that can confirm T3 disease.
Yeah, or the other.
There is no other method that we have for that.
Or the other option is
Yeah.
send the kidney for frozen, clip the ureter, send the kidney for frozen,
Yeah.
and if it's renal cell, great, you're done.
Right.
But if it's not,
Yeah.
go for the ureter.
Okay, so now we have to think about a couple of risks, right? You're worried about the ureteral stump. You're worried about nodal disease with T4. And so what really takes precedence here? How are we going to sequence therapy? Do you give adjuvant chemo? Do you go and resect the retained ureteral stump? Or do you just do surveillance, cross fingers and hope that they do okay? Do you have strong feelings about one or the other, Adam?
Patient's got nodal disease. Patients need
Okay.
systemic therapy.
Okay.
And then, if the patient does well, resect the stump.
Okay, and Dr. Cole is nodding her head in agreement. So this patient, what's this patient's risk for metastatic disease? Let's try to be objective, right, rather than just going by gut feel. The risk for metastatic disease, there's actually, several ways that we can do this, and I'll show you in the next slide. But then let me ask you this, what's the risk for ureteral stump recurrence? And quite honestly, I don't know what that risk is. We don't have that data. What I do know is that there were no ureteral tumors. The ureteral margin was negative, and I did scope the patient at initial presentation and made sure that there was no residual tumor in the stump or the bladder. So based on that, what are you going to tell the patient about the risk of recurrence there? Adam, what would you say of those values?
For the risk of stump recurrence,
Stump
you said?
recurrence.
Again, we don't know. I'm going to say it's relatively high. I'm going to guess maybe 30 to 50%.
Yeah, who knows,
I don't
right?
know, but
Well,
I
we
mean,
don't know.
yeah.
But
I've managed those patients,
Yeah.
and it's, yeah.
Yeah, and we get them for sure, right? But in this particular case, you have a competing risk with metastatic disease, which resection of the stump is not going to fix, and potentially delay necessary treatment. So, but you do want to be somewhat objective, and there's many ways of assessing post-nephroureterectomy risk. I personally like the last one that's listed, the crab nomogram that was developed by Vitaly Margulis, that's Southwestern. And it's nice because it's color-coded as well. And so if we plug the numbers in for this patient, she has a very high risk of developing relapse, and her recurrence-free survival at 2 years is 23.8%. So this is very high-risk disease, and it's life-threatening, essentially. And so based on that, our recommendation was to proceed with adjuvant chemotherapy in a timely fashion. And then after that, we actually monitored the patient just to make sure she wouldn't have a rapid recurrence, continued surveying her endoscopically just to make sure that we weren't missing any recurrences locally, and then eventually underwent a salvage ureterectomy with bladder cuff. I elected not to do a lymph node dissection at this time. Mind you, she did have a positive hilar lymph node, right? Was I wrong? Adam?
I don't think so.
Would
I
you have done
agree.
it?
I mean, it's post the fact, right? You're going back in a space, previously operated space. It's going to be a challenging dissection. There's no known benefit. I don't disagree with that.
And they're post-chemo, and so
Yeah.
I think you're probably going to have some good sense of what the lymph nodes look like. But if you were worried about that, at our institution, we do a lot of consolidation with radiation if there's a worry that there's a lymph node that could be harboring disease.
Excellent. Great
Yeah.
points.
And
Thank you.
there were no clinically enlarged nodes.
Exactly,
Correct.
right,
Yeah.
correct. Yeah, so patient did very well for 4 years, went back to local follow-up and survivorship after that. So any questions about that case before we go into this next one? Adam, is there anything online?
Thank you. What are your thoughts on taking the ureter in NU? Is open bladder cuff easiest, excision safest, excuse me. What are your opinions on cystoscopic assisted bladder pluck technique?
I don't do anything except basically resect the entire distal ureter and bladder cuff under direct vision by whatever way if I'm doing it open or robotically, I want to visualize and visually confirm that I see the orifice in my during my resection. So Adam and I were talking about it. There are slightly different techniques. I actually like to divide the entire lateral pedicle even when I'm doing it open, but definitely with robotic. Most of my patients are very obese, so I can't approach it purely posterior. But that allows me to bring this posterior intramural portion and rotate it and work in an anterior location where I can visualize it and also close the bladder cuff in watertight fashion visually. Adam, you have a slightly different approach for that.
Yeah, I'll just
but
comment.
the idea,
yeah.
I think, is the same, which is that you want to do it under direct vision. Yeah.
Yeah, and yeah, you want to do it under direct vision. You know, I mean, the one, you know, leaving the tunnel and, you know, assessing that cystoscopically after it's known there's a higher risk of bladder recurrence. I don't divide the pedicle. I take the ureter into the bladder, open the bladder. I think just in terms of getting a watertight closure, before you actually divide the other side of the ureter, pre-place your suture. It
Right.
makes so it doesn't retract. It makes it a lot easier. I actually pre-place both sides and then meet in the middle.
Very good.
Yeah.
Yeah, thank you. Thank you. Okay, let's move on to the next case, solitary kidney with high-grade upper tract cancer, and we're going to highlight screening for a hereditary syndrome. So this is a patient actually who had a colorectal cancer at age 54, also metastatic prostate cancer and hormonal therapy with good PSA response, diabetes, sleep apnea, former smoker, did have a left upper tract cancer that underwent nephroureterectomy. As you can see, it was actually a pretty bad disease. Didn't get any chemotherapy before or after. Remarkably did pretty well. That was over 5 years ago. Family history is really only relevant for mother and 2 maternal aunts with breast cancer. So, you start thinking about that. CT chest is negative. GFR is reduced with that single kidney at 43. There's no evidence of metastatic disease. And basically, we see a bulky tumor in the upper calyx, and at the time underwent subtotal laser ablation. And the hopes that it was low grade, of course it wasn't. What the biopsy shows is that it's high grade, and you can see the CT there with the retrograde polygram and the endoscopic view. Okay, and the washings are also positive for high grade disease. Okay, now before we move on to management, what's the suspicion of inheritable syndrome with this personal and family history? Is there not? He was a tobacco smoker, right? So maybe it's just a tobacco-related cancer. Suspicion for BRCA is there because of the family history. There's really no family history of anything indicating Lynch syndrome in terms of colorectal cancer, endometrial cancer, sebaceous cancers, prior upper tract cancer. Suspicion for VHL there is to kind of throw you off a little bit because that's what people think about. Of course, not related to upper tract cancer, and tuberous sclerosis also not related. So Lynch syndrome is the one thing that we do want to think about with this disease. And there's a couple of different ways of screening for it. There's the clinical criteria, which come from the colorectal cancer world. It's easy to remember as a 3-2-1, 3 successive generations with LS-related cancers, 2 of them being first-degree relatives, and 1 of them being diagnosed before age 50. That patient I just showed you met none of those criteria. And what we find, in fact, is that the clinical criteria actually miss a lot of cases. Now, there is a way to screen with tissue, which is a bit more reliable. And probably the easiest way to do it is by having the pathologist do IHC, immunohistochemistry, on the specimens. This is standard of care for colorectal cancer, and it's supposed to be for endometrial cancer as well. We just don't think about it because it's not something that we routinely do, but it is something that you can ask your pathologist to do. And what they do here is even on biopsy specimens, they can do this, where they'll stain for MLH1, MSH2, MSH6, and PMS2. And all those should be expressed. They use the non-urothelial cells as an internal control when they do this. And if one of these is absent, it suggests, it's not definitive, but it suggests possibility of Lynch syndrome. It could also just be that it's a somatic tumor mutation. So in those cases, if there's a suspicion, or even if they're all negative, but you're still suspicious, let's say they're young, it's like that other patient, right, that was less than 50, then you can just send them to a genetic counselor.
Less than 60, the patient was.
Less than 60, yeah. So anytime you have then the way to confirm it would be to send them to a genetic counselor for germline testing. Now, the problem is insurance may not pay for it unless they have some of these criteria, but that's a separate matter.
I'll just say, I have a very low threshold to send people, and I've not had anyone tell me they couldn't get it done.
Perfect.
So,
good.
yeah.
That's good to hear.
Maybe it's in Massachusetts, I don't know, but.
Right, yeah. No, that's great. And then in my own center, every single patient actually is offered germline testing. But I also have a patient who's donated funds to pay for the test. It used to be like $2,000, $3,000, $4,000, $5,000. Now it's only $250 or so. So it's not that bad, but still for a lot of patients that could be cost prohibitive.
But I think this case also highlights, the family history is not just urothelial cancer. The family history is expanded, right? And so,
Great point.
And that's really important. And his personal, he had a history of
He has a
colorectal
history of
cancer,
colon
right?
And upper tract.
And another upper
before.
tract. So he has his own personal history that's really
Exactly.
important. And so, my criteria, anyone who's, 60 or under, even without any other criteria, they go for testing.
And in this case, we screened using tissue, doing the IHC. It actually showed loss of MSH6. Based on that, the patient was sent to genetic counseling and germline testing, which confirmed germline loss of MSH6. And actually, I was thinking it was a BRCA mutation. And we do see some upper tract cancers that are BRCA related, not very often, but we do. But in this case, those were not mutated. And so the patient was referred to high-risk GI clinic, and the first-degree relatives of the patient qualified also for genetic counseling and testing, which at this point should be covered by insurance because of his discovery. And so in terms of the assessing the risk of disease, we see about a 20% chance of having T3 disease or higher, 66% chance of reoccurrence-free probability at 5 years. And so based on this, Dr. Cole, what treatment would you offer?
Well, the fact that he is missing one of his DNA repair genes and that he's, quote, MSI high, He will qualify for immunotherapy through the FDA qualification that if you have an MSI tumor, you can receive systemic immunotherapy with pembrolizumab. Few slides back, he was not eligible for any type of cisplatin-based chemotherapy because his GFR was pretty terrible since he only had one kidney to begin
43,
with.
correct. Yep.
So, we're all very concerned and hesitant when somebody has one kidney to be throwing chemotherapy their way. And so just the fact that he has all of these perfect things that allow us to get pembrolizumab authorized and paid for would be a great choice for him.
Excellent. Go ahead.
And if you go back to that option page, so, if you think about two options there with dialysis, we can't forget about the risk of mortality with dialysis. And I just don't remember his history, but
Well, he's got some comorbidities.
He's got
there,
diabetes.
yeah.
So
Yeah.
what do we think about diabetes, cardiovascular disease? Those are risk factors for that increased risk of and age, increased risk of mortality with dialysis, which is not insignificant.
That's a very good point, but it's not always the case for every patient, right? And if we get to the
Right.
last case, we'll highlight that.
Yep.
But in this case, being elderly, being diabetic, with heart disease, and all that, then that definitely does predict lower survival with dialysis. So we may not optimal, although it is an option for the patient if they really wanted it. But we're lucky in that, as Dr. Cole pointed out, pembrolizumab is the first agent that has tissue agnostic indication. It means it doesn't matter where the cancer is. If it meets one of these criteria, MSI high by PCR test, deficient mismatch repair, which doesn't have to be an LS related, right? I mean, some of the other genes are known to be also mismatched genes. And then, or if it's a known LS related cancer, the patient qualifies for pembro. It doesn't even have to be metastatic, correct?
Correct.
Yep.
So there's a. Oh, you're still going. Sorry.
Yeah, I'm
Yep,
still going.
Sorry
yeah.
about that. Yep.
Okay. So the patient did receive pembrolizumab for 3 cycles, tolerated it, but had a lot of bothersome symptoms that really affected the quality of life. GFR is stable to slightly improved, but surprisingly, with CT and ureteroscopy after the 3 cycles, we see a good response. What the radiologists or medical oncologists would call a PR. But for us urologists, that's actually a pretty dramatic response, right? That size reduction. Now suddenly it becomes reasonable to think about saving the kidney. Do you disagree? Either of you? No? Okay, great.
No.
And so,
Not with one of them.
Can you surgically consolidate, or would you do radiation?
well, not really surgically. The only surgical consolidation would be nephroureterectomy.
So you can't. It's not small enough now that you can resect it.
Laser.
Laser.
We
yeah.
would laser.
And radiation will affect the kidney function, no question. It'll knock out. a
It
signal.
will, but it just depends on your radiation oncologist and how brave they are. But I have several unilateral kidney patients who have been treated with radiation and they still are not on dialysis. and they're-
SBRT?
Yes.
Yeah, I think, I'm not going to say that I wouldn't do it, but I would be something in my back pocket that I would have as a desperation move. And
Sure.
I'm not sure I would use it in this case. Because also I think you can see the laser probe there to give you a sense for how big that residual tumor is. I mean, it's very, with your thulium or with my diode laser, that's going to be lasered away within 2 minutes.
Yeah.
Right?
Yeah.
And even underneath that necrotic tissue, you can scrape that away. And, if you're worried that there's something at the base, and just treat all of that. Clearly, for high grade, you're going to worry a little bit, but the patient had such a good response that you would think that anything that potentially may have been invasive was treated also. And so you rely on these 2 modalities to kind of, get the tumor from the inside on the outside, if you will. So, patient did pretty good, and actually, but refused any more immunotherapy, was miserable from it. And then 6 months later, we thought we saw a recurrence in the upper tract, so I performed a ureteroscopy. It was negative, great, except we gave him a stricture. 6 weeks later, presented with renal failure. My colleague who was on call placed an emergent stent, and then basically about a month later, I went up to make sure that I didn't miss disease or something, and it was just regular old endoscopy caused stricture, and where you would expect it to be in the distal ureter. So we basically left a stent, I think, for 2-3 months, and then took it out and just very carefully monitored to make sure it didn't recur. Would you have done anything differently, Adam?
No, I think exactly the same way.
Okay, very
Yeah.
good. Any questions about that case? And actually, go ahead, Firas. But I am going to slowly start moving on. If there's other questions, this is also about inheritable syndrome, but we'll talk a little bit more about treatment.
Sure. What if the germline testing showed VUS? Would you offer him pembro? Let's say insurance will approve it. He has Medicare, straight Medicare. No
So if-
insurance issues.
If he was truly MSI high, we have no problem. But I don't think you're going to see that on a variant. Like, I don't think it would show up as a variant of the DNA mismatch repair. It's either missing or it's there. So I don't know that I've never run into that problem, but when people have, other indications for specific mutation, if it is a variant, we cannot get it paid for. They will fight.
I think the differentiator here is that there was no expression. So it's not a VUS because pathologically it is not being expressed, So, but your point is if you don't have the IHC and you're just doing mutation profiling and that's the only data you have, then that might be a harder call. And that's why maybe doing immediate or only mutation profiling may not be very helpful. And that has been highlighted to me by my pathologist because I asked him, why don't we just do that? And the point that was made to me is because not every mutation that we find is necessarily translated to a actionable mutation. And that's why the tissue testing can be very helpful that way.
Yes. Is this a good time? There's one.
Absolutely.
So there's one question here. It says, and I think this was referring to the prior case, but it says, what would you do for high-grade CIS confirmed by cytology and FISH? I lasered the strawberry patches and am now doing surveillance, ruptured calyx, low volume, flat. Sounds like 2 to 3 doses of Jelmyto. So I'll comment that Jelmyto is really for low-grade disease, okay? And that for imperative indications such as a solitary kidney or bilateral disease, we have used it for high grade, and there is some evidence in the response rate. It confirmed that was 40%, but it's very short-term follow-up. And so, I know you are a fan of BCG.
I think if it's CI, I am very reluctant to give Jelmyto for high-grade disease. In the clinical trial, a lot of recurrence. We unmasked high-grade disease that was not treated by it. So I'm very reluctant to do that. For CIS, I absolutely would not use it.
I totally agree.
And if it is a case where I think it's really just quote-unquote pure CIS and there's no visible like papillary or solid tumors, we have given BCG. And with that, it's retrospective, single institution data, so take that for what it is. But we see a roughly 60 to 65% response rate similar to the bladder. And so it seems to be, it's high-risk disease, but it seems to favorably respond to at least the induction BCG. And in my case, I actually, as much as I can, I do it like the bladder, where I will give them at least 2 cycles of maintenance afterward. It's a huge hassle for the patient, but if they want to save their kidney, that's what we do.
Yeah, I agree. Yeah.
Okay.
Yeah.
Yeah, very good. Okay, so in this case, known Lynch syndrome, a patient, a 58-year-old with MSH2 and MSH6 germline mutation, has a history of colorectal cancer with right hemicolectomy. In 2013, I treated a left small volume, high-grade upper tract cancer with laser ablation. At the time, we were using mitomycin and gave him adjuvant mitomycin retrograde. And then 6 years later, it developed a recurrence on that side. This time it's low grade. Again, managed it with laser ablation. And at this time, we had data on gemcitabine, so we were switching, that was the agent of the day that we were giving as topical therapy. And then 3 years later on surveillance imaging, suddenly he's got a bulky right-sided proximal ureter tumor with hydro, and there's concern for T3 disease. There's no metastatic disease or enlarged lymph nodes. And you can see here the arrows showing this bulky ureteral tumor that's obstructive. There's in some of the other images, you see some speculations around the ureter, so there's some concern that it may be like a T3. And there's the endoscopic view of the tumor. Okay, so what are his treatment options? I think at this point we kind of gave it away already. Is there any reason to consider anything other than Pembro, Dr. Cole?
So I do want to say that neoadjuvant chemotherapy is not wrong in patients with Lynch syndrome. They will respond to chemotherapy. They obviously may have less toxicity if they get an immunotherapy treatment, but I think 4 and 5 are both reasonable options.
Very good.
And is there data on neoadjuvant Pembro in this setting?
Not that I'm aware of that's been formally published.
Right.
I think we all have our case series. I was telling you guys about, I have a cardiology colleague who has Lynch syndrome, who's also had colon cancer in the past, and he developed a T3 ureteral tumor, and he categorically refused to take chemotherapy and lose his kidney. And he was aware of the dostarlimab data for colorectal cancer that had recently been published in New York, where these colorectal cancer patients, 100% of the people on the trial had a complete response. And so that drug was kind of just blowing up our phones when all patients were like, I want that drug, even though they didn't have that cancer. But he ended up going to New York and getting on a clinical trial that was looking at patients who had Lynch syndrome and are predicted to respond to the dostarlimab. And he had a complete response on that clinical trial. So I think he made the right choice of refusing chemotherapy.
Very good. So in this particular case, pembrolizumab was given. 4 months later, CT actually shows a complete response.
Mm-hmm.
Yeah? And the question is, what would you do next? And quite honestly, I wanted to scope him. I mean, because that's what I do, right? I mean, I want to look to see if there's any residual disease. I know there may be some small amounts. Maybe imaging is missing. I thought about maybe I should do a segmental ureterectomy if there is anything there, or to prevent recurrence in the area. But patient is pretty adamant, same phenotype as yours.
Mm-hmm.
Basically doesn't want me to touch him. I mean, and he knows what to expect, right? He's been through a bunch of treatments on that left side. So it's not he's not making that decision out of ignorance necessarily.
And it's not easy, right? He's got Lynch. You know he's already had disease on the other side.
Yep.
And it's not an easy decision of, you don't just take the kidney out. I mean,
Right.
you can,
Right.
but that's not an easy decision. And
Patient
it's
won't
not,
let you,
it's-
though. He's
what's
not
it?
going to let you.
But it's not wrong. But it's not an easy decision.
Yeah, exactly. Not
Yeah.
at all. Now, mind you, he did have a severe side effect. He actually developed diabetes and DKA, immunotherapy related. So the Pembro was basically stopped at this point, not getting any Pembro either. And so, I learned a lot from this patient because I realized that my knee-jerk reaction and recommendation probably may not have been perfectly correct. And so, you listen to your patient, and, they may not know as much as you do academically, but I do feel like sometimes they know more in the universe of things.
And I just want to add that
we got lucky and just monitored him and has done well so far. Yes.
for patients who are receiving immunotherapy and they have these like really catastrophic side effects, like their pancreas is necrosed and they can no longer make insulin, and that's why they get type 1 diabetes. So when we have these like very strong immune-related toxicities, it's a sign that the immune system has been stimulated. It's a sign that they are likely also attacking the cancer. And most of our patients who have these dramatic, very severe side effects from immunotherapy also have very high survival rates from a cancer perspective. They may have a permanent debilitating illness that we gave them with the immunotherapy, but they also may be cured.
Yeah, great point. Thank you. Is there any questions about that case before we move on?
No, and I just, for whoever, there was a question in the chat, I just answered it. So.
Okay, thank you. Okay, so now we're going to move on to a bit higher risk situations. This is an upper tract case with node-positive disease. 55-year-old who presents with gross hematuria. There's a right distal ureter sessile tumor. Biopsy shows high-grade urothelial cancer. The patient was seen locally, a stent was placed, and the patient is then referred to us. GFR is 42 at the time of presentation. Imaging shows the right kidney being atrophic. A differential study had already been done that confirms this. There's multiple enlarged regional lymph nodes. You can see on the imaging there, hilar, retrocaval, interaortal cable. They're all to the right of the aorta on the same side as the kidney. There's no evidence of distant metastatic disease. Okay, so if we were going to stage this, it's the TX. We don't really know the local staging. TX, N2, M0, high-grade sessile cancer. Patient has CKD3. What should we do next? Biopsy node, then chemotherapy or IO or ADC. Do an FRU. I mean, not going to lose much kidney function. Or do an FRU with nodes. Or do you just remove the distal ureter and do a reimplant? Is there a right answer here or a wrong answer?
Well, it's tempting. It's tempting to say, oh, the kidney's got no function. Let's just take it out.
Yeah.
But that's
we
not
can
the
remove
biggest
all the
problem.
lymph nodes, Dr. Feldman. We can
Th-
remove all
that-
the lymph
but-
nodes and
but-
render them disease-free.
But that patient needs systemic therapy.
Okay.
That's what that patient needs to start with.
Yeah.
And this is probably the guy that I would do a PET scan because there's all this very multiple lymph nodes near the kidney. That's a highway. The retroperitoneum goes like all the way up through the mediastinum. That's why people get these left-sided supraclav nodes. So you might find that the disease is much more extensive. But I also want to point out that clinical N2 disease is stage 3B, so it's like right on the edge of 4. And this is a locally advanced patient that now that we have an approval for EV-Pembro, we are really leaning towards EV-Pembro and away from systemic chemotherapy, mostly because about 30% of the patients in the trial were upper tract patients who had locally advanced disease. But the compelling part of it is that if you got onto EV-Pembro and you were a responder, 30% of patients went into complete and durable remissions, i.e. they have possibly been cured. And, we've just never seen data like that in locally advanced stage 4 patients with bladder cancer, that they are living many, many, many years at this point. And so I really offer that first to anyone that's in that category because I want to have the chance to get them into a CR.
So I don't know the answer to this. Does a biopsy-proven retroperitoneal node count for approval for EV-Pembro?
So yes, so locally advanced will count, and multiple lymph nodes in the retroperitoneum are definitely meeting the bar. And the other issue is, can your surgeon resect everything? And some will say, yes, I can do it all, but like if it's not possible or you're not wanting to do that up front, that by definition is meeting the criteria of the patients who went on to study.
But you're delaying their systemic therapy,
Yeah, and
I think, which is really what they need.
Yeah, and my, I was obviously playing the, I was playing the devil, not the devil's advocate necessarily, and suggesting we do surgery first. But the point being that this is not a surgical situation. Yes, we can maybe feel immediately gratified because we're removing all the disease, but that patient is going to recur. As that graph shows you, they're going to recur very quickly, and they're going to have explosive disease, and survival is going to be awful while they're recovering from the surgery that they should not have had at the first place. So the point here is that systemic therapy would be indicated with lymph node positive disease. And then as Dr. Cole already mentioned, her go-to at this point would be EV-Pembro, which is a recent development within the past year. As it turns out, this case is a bit more historical. Before this was available, and so this may not be relevant now, although there may be situations where it could be if patient isn't a candidate for EV-Pembro. At our institution, there was someone is not cisplatin eligible. They give this gemtaxol adriamycin as a nephron-sparing initial chemotherapy, because what we notice and have observed and have published on this is that many times as this chemotherapy is working and the cancer responds, their kidney function improves for reasons we don't fully understand, but we definitely have observed. And once that kidney function improves to a certain threshold, then they switch to cisplatin. And then so the patient got MVAC for 5 cycles. And what we see now is a nearly complete response radiographically. And so just to kind of cut to the chase, because of the very satisfying radiographic response to chemotherapy, the patient then underwent open nephroureterectomy with an extensive lymph node dissection of all the previously diseased sites, and then maybe a little bit more intravesicular chemotherapy. And pathologically, what we see is, again, very gratifying to see that, in fact, the chemotherapy was highly effective. There is some residual disease that's non-invasive. There's carcinoma in situ. All the lymph nodes are treated without evidence of residual disease there. And then we were, of course, screening for Lynch syndrome this case, and there was no indication of it. Any additional thoughts here?
No, I think, and you can see, you plan your lymph node dissection by the pre-systemic therapy films.
That's a great point.
Right.
That's a
Not
great
by
point.
the post.
Thank you. This is like out of the playbook with my fellows, because when I go to those cases, I usually look to see which films they put up, and usually it's the post-chemo films, and I need to remind them that what we really need is the pre-chemo images up, because you're gonna miss resection of consolidation of disease unless you're looking at those.
Because there's
Thank you
no
very much.
clear template,
great.
right?
Yeah, we didn't plan that. I'm really happy to see that we think alike. So, so again, chemotherapy is the primary treatment. It's not neoadjuvant. And then, but generally, I don't know with EV Pembro if it's the same concept where you give a little bit more after you see like a maximal response. Do you give extra, or is there sort of more fixed regimen?
So honestly, if you do choose to go EV Pembro, you're basically saying this is out of the box, and you may never go to surgery. So like we're very clear with the patients that, you know, we're really hoping to control your disease. If we get a really great response, we might be able to pause for surgery. But if you're in that 30% who has the complete response, you may not need anything else.
Very good.
You know, kind of like the Lynch syndrome patients. It's a way to kind of overcome the fact that not all of us are going to have Lynch syndrome and respond beautifully to immunotherapy. That enfortumab is a really strong partner.
Very good. And so this goes back to one of the pretest questions you got, which is that surgery here provides consolidation after we see that there's been a good response to chemotherapy. So if it's an extremely rare situation where the patient is progressing on chemotherapy, surgery would not be the answer either. Correct? Would you agree? Yeah.
And just one more thing I'll throw in there is, you know, this is early days for us with just seeing what happens to patients on EV Pembro who may have never been, you know, operable to begin with. Sometimes we are seeing like these dramatic, profound responses where we can go in and consolidate the kidney with surgery. But we're also doing quite a bit of radiation therapy to the areas of disease that were present to consolidate without operating on them and taking something out of their body, particularly when it comes to intact bladder patients. Which I know isn't this session, but we're definitely
And
getting
to
more
clarify,
data.
you're talking about SBRT,
Yeah.
right? A SABR and not
Saber,
traditional radiation. Okay,
not
so
not
yeah.
long-lasting radiation, but we're walking into those realms.
So, Suzanne, I have a question. If there was active viable tumor in the nodes, or would you consider giving adjuvant Nevo?
So
And what happens if you give someone who has had Pembro Nevo? I don't know the answer to that.
If we had started with chemo and then give Nevo.
You've given EV Pembro.
Mm-hmm.
Can you? There's data on adjuvant.
Yeah, so there's
Nevo, you know what I'm saying?
There's no data on post-EV Pembro
I know.
immunotherapy. We're actually running a trial that's almost live from ECOG looking at that question. But I would only do adjuvant Nevo. I have actually done sometimes for patients who did not receive any neoadjuvant anything, ended up having very bad disease. I have sometimes given them a full course of chemotherapy, whether it's GemCis or CarboGem, and then I move right into Nevo because they're so high risk. And I can't always get that paid for, but sometimes I can, so I just try.
Is there any questions about that case before we move on? Very good. Okay. So this case, we're going to talk about a post-cystectomy ureteral cancer. 75-year-old who had undergone cystectomy and node dissection with a Studer pouch for a BCG refractory CIS in many years prior. 6 years later, on surveillance imaging, there's left hydronephrosis. There's soft tissue in the left ureter. There's no evidence of metastatic disease. GFR had dropped from 47 to 22. The patient does have some significant comorbidities, has Parkinson's and dementia, needs the spouse is a major caretaker. And then here's the imaging that shows a long segment of the ureter with this bulky tumor. And it's, you know, there's speculations there coming out of the ureter. It's very concerning for T3 disease. How would you biopsy this and diagnose this, Adam?
Yeah, so I mean, personally, I would have that patient get a percutaneous access and refer him to one of my colleagues for a ureteroscopic biopsy. I know you can potentially do a percutaneous needle biopsy of the ureter. I haven't used that, not in the ureter, but for if it's a large invasive mass, then you can certainly.
Yeah.
But I think percutaneous nephrostomy and then integrating ureteroscopy.
Yeah, so the one advantage of that is that you're also relieving the obstruction, you know, if you do
Yes.
it that way. And certainly that's fine. I actually happened to have been at the AUA when this happened. And so what we asked them to do was to put a nephrostomy in and at the same time do a perc biopsy so that we could expedite management of the patient.
And it's a win-win if you can actually get that done.
Exactly.
I mean, it's great.
Absolutely.
Yeah.
And so, and in terms of, you know, there's concerns about percutaneously biopsying urothelial carcinoma, and those are well-founded. And we're using modern techniques with experienced interventional radiologists. We don't see a concern, and we have published on this, as has the Mayo Clinic,
Yeah.
in terms of the safety of this, as well as the diagnostic feasibility of doing it. what you need is a targetable lesion, essentially, like any other IR biopsy procedure.
It's a coaxial
So-
sheath that they use,
Exactly.
that they don't pull
so there's
tissue
safe
through
ways
the tract.
of doing it.
Yeah.
If you don't do it safely, yes, there's a risk for seeding. But we have not seen that, and at this point, we've probably done over 40 or 50 patients this way. So the biopsy shows poorly differentiated carcinoma compatible with a urothelial primary. GFR improves a bit back to what the baseline was of 45 to 49. And just to kind of cut to the chase here, a patient was given cisplatin, gemcitabine, and ifosfamide. Don't ask me why that particular combination. But Dr. Cole maybe can explain that
this-
off,
I can't explain it, but with the dementia and Parkinson's, I'm just kind of perplexed. I don't know that I would have been that aggressive.
Okay, but you would have
And
given
I'm
something.
pretty aggressive, but I'm kind of like,
Pre-EV Pembro, you would
Why
have
the
given
for sure.
something.
ifosfamide? Why the
For sure.
ifosfamide? Okay, yeah.
So after restaging, after 3 cycles, a restaging CT was done that showed a good response, and the patient underwent an open nephroureterectomy with the cuff of the pouch and the lymph node dissection. So these cases can be very difficult post-cystectomy, if you're asking why this case was done open, and I showed you a prior case with extensive nodal disease that I did open. Usually after nodal disease, there can be tremendous desmoplasia around the great vessels, and also the handling of the lymph nodes, I feel like you have to be much more careful with, particularly with urothelial disease. And quite honestly, these days with enhanced recovery pathways and regional blocks, I have no qualms about doing the case open if I feel like I'm going to do a better surgery that way. That the benefit of that long-term outcome trumps any of the short-term benefits from MIS, which is my opinion. Not everybody may agree with.
Yeah, I probably would have done a robotic
Okay.
nephroureterectomy, and then the right side's a lot easier than the left to get down to the
Agree.
conduit or chimney, depending on whether you did a neobladder. The left is a pain because you have to get you've tunneled it under the sigmoid mesocolon. You have to chase that down, but you can. For that part, you can then make an incision, and then that would be your extraction site, and do that part open.
The difficulty I've had with that, and I don't want to get
Yeah.
into much of a discussion, but the post-cystectomy, usually there's all these adhesions down into the pelvis. So even though you make that incision there, you have all the adhesions down in the pelvis that you have to release in order to be able to get a safe view of everything. So for me, again, I used to do a lot of these endoscopic, or minimally invasively, but again, with the really good rapid recovery we're seeing with enhanced recovery pathways, again, I want to get my day done and not be in the OR till late in the night. Maybe like some other people, so So anyway, just to show you the percutaneous biopsy in this case that was done, and then the post-chemotherapy response. And we already talked about this, why the percutaneous biopsy and the safety of this, so I'm not going to go over that. And then basically what we saw was actually a complete response. There was no residual disease. So oncologically, we feel very good. Poor guy has got not great kidney function at this point, but I'm not sure, we had really great other options in this case. How would you follow this patient now with this low of a GFR, Parkinson's, dementia, may not sit still? Oh, actually has a pacemaker.
Oh.
Yeah, I'm not making that up. The patient has a pacemaker, so MRI wouldn't be that easy either, right? So
I like this. PET
goes back to
scan
the
idea.
PET question.
Yeah.
So this is one of those narrow indications where I would offer the patient a PET because I can look at everything with one quick scan. And so, thank you. We planted your question early on for that reason. Thank you. Any questions about that case before we move on?
Let me just.
Dr. Feldman's going to check
No, we're good.
live stream. Okay, very good. So let's see. We're doing pretty good on time, I think, right,
Yes,
Jake?
yeah, we have a half hour
Okay,
left.
perfect. Awesome. So I think maybe we have a chance of getting through most of these. So another ureteral cancer. This is a 49-year-old male with about a year and a half history of T1 high-grade disease with CIS, so high-risk bladder disease. It was treated with TURBT, BCG induction and maintenance, and that actually right now looks pretty good. Granted, it hasn't passed the long test of time, but there's no evidence that has recurred. Develops right flank pain, goes to the emergency room. They see right hydronephrosis with inflammation around the ureter. He was recommended follow-up imaging. About 2 months later, gets an appointment, and right hydro is seen again with a mass in the distal ureter and a 2-centimeter interaortocaval lymph node. Again, the tumor's in the distal ureter, the lymph node is interaortocaval. Biopsy is done, of the lymph node, which shows poorly differentiated carcinoma. Ureteroscopy shows a sessile tumor in the distal ureter, actually have muscle in that specimen, which we don't see very often, so clinical T2. we are able to scope above that. There's no multifocality. There's no other tumors. Bladder is clear. GFR is 74. There's no metastatic disease. A mutation panel happened to have been done, and this shows FGFR3 and P53 mutations. Okay, so lots of data there. Here's the imaging showing the tumor in the distal ureter, and then showing the lymph node in the upper retroperitoneum, and then there's the retrograde pyelogram. Adam, are you surprised by seeing a lymph node metastasis in the upper retroperitoneum from a distal ureteral tumor?
Am I surprised? No,
Yeah.
we see a lot of different stuff in upper tract. I've seen it all. But no, I'm not surprised, and it's not like it follows an exact pattern and a sequential pattern. So.
Yeah, and this is to actually the data isn't great because there's not that many patients, but what we have shown in some lymph node mapping studies is that these distal ureter tumors actually do have primary lymph node metastases in the upper retroperitoneum as a first site of disease. And this case highlights that situation. There's no pelvic lymph nodes at all, and so that's just to show you that it's a observation that has been made, repeatedly.
But
And we're
that-
actually revisiting that data soon to publish it again.
But that being said, your
Yeah.
standard lymph node dissection for a high-grade distal ureteral tumor is a pelvic node dissection, correct?
Pelvic, yes,
Yes.
and I actually, because of the data that we have,
Yeah.
I do try to go higher if it's a patient who's younger and
Yeah.
feel like the extra surgery is that they
Yeah.
can tolerate it. Yeah.
And this guy's the 49-year-old, right?
This patient is fairly young, but 49.
Mhm.
Yep.
Yeah.
Yeah. Can you come to the microphone real quick?
I said a credit to IR. They were able to biopsy that between the great vessels.
Right.
They're pretty good.
Absolutely.
They're pretty good.
Exactly. All right. So we talked about the first bullet. Is he a candidate for distal ureterectomy, and what should be evaluated? And I'll show you that next. But I'm going to ask my colleagues here, what are the options here?
I think this guy needs everything. We definitely would lean towards upfront neoadjuvant cisplatin-based chemotherapy. I can't remember what his GFR was.
70 something. Yeah.
Yeah, so I even if it was like lower, I would really try hard
Yes.
to split the cyst or do whatever we could.
The
to
node
get-
positive disease is
Yes,
the deal
yes.
breaker, right? For
Yes.
any initial surgery option. Even a distal ureterectomy, even if I could preserve the kidney function,
He might have 5 lymph nodes by the time you're done with him, so I want to get in there first.
perfect. Thank you. Yep. Adam, any objections to that?
Upfront systemic treatment? No.
Correct.
Yeah, not at
Very
all.
good. So if you want to consider distal ureterectomy, it's it's a bit of work, right? It's not just a slam dunk because you need to rule out multifocality, make sure that there's no disease higher up, provide yourself a clear roadmap and anatomy for planning the ureterectomy. The last thing you want is a positive margin, which is potentially fatal, and making sure that there's no bladder disease for one thing, and especially in a patient like this with a recent history of high-risk bladder disease. But also make sure they actually have adequate capacity and function. And if that's a concern, then they may need more formal evaluation of that. So just to make those points, that it's a bit of effort on our part to consider that. In some cases, may be worth it.
And you mean capacity for reconstruction to
Yeah.
elongate the bladder and bring it up for OSH. That's really important.
Yeah,
That I think-
absolutely.
yeah, you can't forget about that part.
Exactly. And so this patient got the dose dense MVAC for 6 cycles, and don't ask me why they got extra, but the idea there again is the going beyond 2 cycles beyond maximal response, and I think there was a tolerability issue with that MVAC. So imaging-wise, what we see is a complete response. You can see that area in the ureter has actually kind of opened up. And then one more reason to provide yourself a good roadmap for surgical consolidation before treatment, because if we were to plan it based on response here, it would be really hard to know where to resect the ureter. And so in this case, the patient did want renal preservation. We actually did a repeat ureteroscopy to make sure that there was no new disease higher up. And then essentially distal ureterectomy, right pelvic nodes, retroperitoneal lymph nodes, of course, with the area that was previously affected. And fortunately, we were able to just do a psoas hitch reimplant. And again, very gratifying that the chemotherapy here provided a pathologically confirmed complete response.
And I'll just comment for
Yeah.
distal ureteral tumors, if there's an obstructing tumor that you can't get a flexible ureteroscope past,
Yeah.
that's the situation that again, place a nephrostomy, ask your colleague to do I don't do them, percutaneous antegrade ureteroscopy. You have to assess above. I know some people will put a ureteroscope in at the time of the surgery to look, and I like to even know that what looks normal is not CIS, occult
That's
CIS.
a good point, yeah.
Yeah.
Yeah, I think the idea of doing ureteroscopy in an open field is very unpleasant to me. But I know people do it, and it
Yeah.
turns out fine.
I've done it,
It's hard for me to do that.
But it's important because I've seen patients referred in, and the above the tumor has not been assessed, and you have to do that.
So a clinical T2N1 sessile tumor that it's YPT0 N0. What's the prognosis here, Dr. Cole?
So just because he has the lymph node in its upper tract, I would say from his first clinical stage, overall survival probably 50s, 60s, but because he has had a pathologic complete response, he's probably closer to 80.
Okay, very good.
5 years
At which point can he ring the bell? At which point do you tell the patient the odds of recurrence are so low now, you can have monitoring, but
So-
really I don't want to see you very often?
Realistically, in the med-onc world, if you are destined to recur, it's going to happen to you in the first 2 years. Only about 5% of people will actually recur in the third year of follow-up, and then there's just a tiny fraction that are in the fourth and fifth year. But we scan them the whole time, and we're seeing them for 5 years total. And then when they hit the 5-year mark, I'm giving them a high five. I tell them they're graduated. They never have to see me again, except maybe in the grocery store. So, congratulations, they're on their way.
Excellent, thank you. Any questions about that case?
Would you be giving him 4 cycles and not 6 for N1 disease?
So I tend to also go very far, especially I think it was maybe 2 ASCOs ago, it might have been just last year. There was a French study that was published with 6 doses of MVAC, and every additional dose of MVAC that you got into the patient, their survival went up by like 10%.
Wow.
And so the lines were like approaching 90% overall survival if you got all 6 of the MVAC.
Overall or cancer specific survival?
Like cancer specific,
Okay.
but it was impressive, these are really big numbers for a very bad disease. And so it changed my practice. I was doing 4 for a very long time. And this last year, I started pushing for 6. It's still very hard in our older patients to get that much chemotherapy into them and not hurt them. So you have to be really careful. Not many people can do it. It tends to be these 49-year-olds.
Is there any questions from the live stream?
No, a couple things, and you still have to think about recurrence above in the ureter above. I mean, make your anastomosis wide because you can often
Thank you
get
for going back to that. Thank you.
You can get the flexible cystoscope and
Yep.
do it in-office ureteroscopy essentially.
Yeah.
But I have become very cognizant and aware, that even though you can bring a psoas hitch quite high, that, and the higher the tumor is, the higher the risk that you're going to then have a recurrence up in the kidney later.
Yeah.
And that's what I worry about.
Got it. So let me ask you, how often would you do, when would you stop doing ureteroscopy and just look at the CT in a case like this?
Yeah, so I don't, so depending if it's a distal,
Let's
I
say
don't
distal, yeah.
automatically, I don't automatically do. I do imaging follow up, and I
Okay.
do a
You
part
don't
of the.
do any ureteroscopy after?
I mean, I will do it 6 months, and then
You'll do
but
once or twice maybe?
Yeah, but
Okay.
but
You don't do it every 3 months for a year?
not for if it's about no.
Okay, yeah, I
Yeah.
don't either.
Yeah,
Yeah,
I
I'll
mean-
scope them once or twice and then
Yeah.
rely on imaging. I agree with you, yeah. That's too
Because-
much.
Yeah,
It's too much, yeah.
I mean, yeah.
Yes, we have one question from the audience. Please go.
Yeah, no,
Can you come up to the mic? Yeah.
I think you answered my question because I was going to say cystoscopically how you're going to maybe you're not going to continue scanning, but you're cystoscopically going to continue to follow them a long time.
Yeah, for sure, with the active
Oh,
bladder disease. And I think I didn't go into this necessarily. I think we put him back on. Actually, I have the question there. Do you continue maintenance BCG? And, we did actually because he had such high risk disease. But yeah, in the office, when you're doing an office cysto in these cases, sometimes you can drive the scope all the way up, in which
Yeah.
case I find it hard to look at every single calyx in that way. But, it's a good, quick screen. But in terms of doing a really thorough ureteroscopic evaluation, I do that once or twice. And I have had a couple of cases where patients have recurred. And so I do. But I also think it's too much to do what the textbooks say and the papers say to do it every 3 months.
Yeah, I agree. You're in the office. You're limited by the length of the cystoscope
Exactly.
to get there.
Exactly.
But the other thing is, doing it, you have to be aware, when you're talking about going every 3 months and doing under anesthesia, ureteroscopy, there are cognitive effects
Absolutely.
on elderly patients in
Yeah.
particular
Yeah.
of repeat anesthetic episodes. So you have to be really cognizant of that.
I completely
Yeah.
agree. Yep.
The one thing I want to clarify, there was a question about, said refluxing BCG up into the kidney. And I just want to and I answered this and I said, that you will not get adequate BCG refluxing up through a double J stent given in the bladder. That's really important to know. You will not get that any
Not
whether it's
reliably at all.
chemotherapy or
Right.
BCG, not reliably. And I just want to clarify my point. But you can in the office place a ureteral catheter and then drip it through the ureteral catheter up into the renal pelvis. So that I have done and you can do.
What about in this case? You did a psoas hitch and it's all refluxing. What do you think? Maybe we're getting some in the upper.
I think likely it will reflux as higher, but you don't forget you still do have the peristalsis down the ureter that
You
prevents
do,
it
yeah.
from going
and
up.
and I wonder if that volume that we give is really that, it's 50, was it 50 mLs, I guess? So it's really
about
not that
50 mL,
much,
it's not a high volume.
Although
But
you can have that patient stand on their head for a while, maybe, and that could help.
Yeah, but I will tell you that in patients who have had bladder cancer that I've treated, I've had to resect the UO, and then they have a refluxing orifice. I know I have created upper tract disease in those patients. I know I have.
Interesting. Okay.
A couple of them.
Okay, last case. Thank you all for sticking around, both in person and the people who are still here live stream. All right, so this is a 58-year-old patient who had a right nephroureterectomy in the past. We have no idea what the stage or grade of that was, but she seems to have been doing well up until this point. Overall, very healthy, good performance status, great functional capacity, very active person. Develops bladder CIS, and then gets BCG induction. Maintenance was not given, and then had recurrent low-grade tumors that were managed in the office. She's then referred because she develops left-sided upper tract cancer. This is her solitary kidney now. And biopsy shows high-grade TX, maybe suspicion of some lamina propria invasion, so possibly T1. It's at the UPJ in the mid-ureter and the distal ureter. It says ureters, but that's incorrect, so just the left distal ureter. And in the bladder, we have active CIS. Here's the imaging. You can't really see the multifocal disease in the ureter very well, but there are some arrows there kind of highlight where these were found. All right. And so this is a solitary kidney, multifocal left clinical T1 with recurrent bladder CIS after BCG. What are the options? We give neoadjuvant chemo with or without endoscopic management to try to preserve her kidney, and then maybe some topical therapy for the bladder CIS. Do we do just cystectomy, ureterectomy, and then ileal conduit to preserve the kidney basically, but just the renal pelvis and just put a high ileal conduit? Or do we just do a pan-urotheliectomy with cystectomy, nephroureterectomy, and put her on dialysis? Or do we do a nephru only, keep the bladder, start dialysis, and then retreat the bladder with BCG?
Well, the one outside of the box option you don't have here is an ileal ureter from the renal pelvis to the bladder and gemdosi in the bladder. But
okay,
I'm not saying that's the right thing, but
Okay.
It's not an easy question. And again, you have to consider her risk on dialysis. That's certainly an option that has to be discussed. She's young, she's healthy. Her risk she doesn't have any major comorbidity, right?
Correct.
So, she actually would probably do fairly well on dialysis, and hopefully then would get to transplant. So, that's a real option for her. Don't forget, all of these other options are a lot for someone to go through. So that's a real question, and you haven't managed necessarily, unless you're taking the bladder out, but that's a lot to go through.
I want to come back to one of your prior points that you made, that the higher the disease is, the higher risk for recurring higher up.
Yes.
And in this particular case, with the multifocality and disease being all the way at the UPJ, you really have to be concerned about preserving that renal pelvis, right?
Yes.
Even though you may not have seen something, odds are there's something there.
So you're
will be there.
Yeah. So if you do like preserving that, which has a very high risk of recurring.
Exactly. Yeah. And this is actually a pretty smart, well understanding patient in terms of what the situation was. And even though at this point she has had some exposure to the effects of urothelial cancer treatment, both surgery and the topical treatments, and basically was tired of all of it. And she just wanted the single most effective oncologic treatment, was completely accepting of dialysis, and wasn't actually interested in transplantation at all. So it was like, okay, very good. Let's send you to a nephrologist so you can kind of start having this conversation. And since she wanted the most effective oncologic treatment, and we had a high-risk condition, we all agree with that, right? T1, possibly high-grade, multifocal with CIS. We offered neoadjuvant chemotherapy, and then basically consolidative nephroureterectomy with cystectomy, which we did robotically, and had dialysis catheter placement at the time of surgery,
So
vascular access lines.
I have a question for you.
Yeah.
So, was her kidney function really poor? Was she already on dialysis? Was she very close?
No, kidney function was actually pretty decent. I'm sorry if I didn't
That's a
include
great
it.
question. If she were
Yeah.
close to dialysis, or
She was
on-
cisplatin.
yeah.
No, she was cisplatin eligible, so she had good kidney function.
She was with
Yeah.
one kidney, and
Correct.
it looking like that.
Yes.
Because
Yes.
I just was curious, giving MVAC, did you push her into dialysis before she went to surgery?
No.
Or it was all just surgical?
No, it was all surgical, but I think because she was going to surgery, I don't think there were any, there was no hesitation in giving the full, and again, really good, from every other respect, no cardiotoxicity, no odor, she had no hearing loss or any other concerns that sometimes you guys have for reducing the doses. And so I think she really got like the full-blown attack of chemotherapy. So, yeah, so remarkably, actually she still had locally advanced disease on final pathology. So this is a case where it's hard to know how effective the chemotherapy was. Maybe it halted the disease, but didn't really effectively cause any downstaging or regression. There was it's T3, multifocal, there's CIS still, all the lymph nodes, ton of lymph nodes there, all negative, thankfully. And so the one point about monitoring here is, yes, you could do a PET scan, but there really is no hesitation about giving contrast here, right? There's no kidney nephrotoxicity to worry about. What you do need to worry about is volume overload. So it's okay to give CT iodinated contrast in these cases. You just need to make sure that they're set up to get dialyzed within 24 hours. Yeah. I have not had an issue doing that, and I do that fairly routinely. I don't know if you agree with that, or if you do anything
I
differently.
use I+.
Or would you rather do a PET scan and not
No, I
worry
use
about
I+ imaging with patients on dialysis all the time. And
What's
they're
I+?
Sorry, contrast enhanced.
Oh,
IV
okay.
contrast.
Oh,
IV,
gotcha.
IV
Gotcha.
contrast, yeah.
Okay, very
Yeah.
good. I learned a new term today. Thank you.
Yeah,
All right.
and in the future, she's going to get a genetically engineered pig kidney.
Okay, all right, very good. From MGH, probably.
Yeah, that's right.
Okay, all right. You didn't give us that disclosure at the beginning. Okay. All right, so at 5 years follow-up, the patient actually did remarkably well. I would say in the first 2 years, every time I met with her, I was like, are you sure you don't want to be considered for transplant? Flat out no. Enjoying her quality of life on dialysis, and these days they can do home dialysis. I don't think peritoneal necessarily was an option, but they actually have home hemodialysis that can be done. And so we eventually transitioned to a survivorship clinic, and this patient is actually about 10 years out at this point and, has done well. And so we can take any questions from the audience and then basically summarize at this point.
So she has a still active disease, residual disease after all that chemotherapy. If she would be interested in transplant, when do you give her the clearance? After a year or two from observation to go have a kidney? Let's say she want to be
think they
listed and when we get to transplant.
They have very strict guidelines on this because we have to often clear them for all kinds of reasons. But I would say not more than 3 years if you have a living kidney donor, and I think 5 for a cadaver donor. I think that's
Yeah, and
what
it does
rules are.
vary from, haven't done transplants in almost 2 decades now, but from my understanding, there's no unified criteria, right? It's very dependent on each transplant center. But for a case like this, I think it would be 5 years, and if they asked my opinion, I would say, yeah, I would wait 5 years, because I would worry. Yeah, it's high
Yeah.
risk. I mean,
Yeah.
granted, this was 10 years ago, so, we didn't have any of the adjuvant options we have now. Had she been treated in this day, would you have offered her adjuvant therapy?
So because she did have T3 disease,
Mhm.
after all that chemo, she would have qualified for nivolumab.
Yes.
Yeah.
Yeah, but she's on dialysis, Dr. Cole.
That's great. We do
Okay.
it all the time.
It's okay.
I do it all the time.
Excellent.
Yeah.
Yeah, that's what I thought.
There's no data, but they're fine.
Okay, right. I mean, it's not renally cleared, right? And so, or anything. So, great, perfect. Thank you. Is there anything online, Adam?
No.
Okay, very good. Oh, one more question from the audience.
I just had a question about screening for upper tract disease after bladder disease, which is a bit off topic, I suppose. But look, in my experience, I've got all these patients who are getting CT-IVP, cytology and stuff. You never, in my experience, and I mean never, find an upper tract TCC with those methods. The patient always presents with hematuria. So I know, or they're always found some other way.
Right.
So I know what the guidelines say, but I'd just be wondering if your clinical experience correlates with that and whether you think the guidelines maybe should change.
So, yeah, I mean, I doing an I plus CT, or whatever, CT urogram, I'll just say a CT urogram.
I like iPads. Stick with
yeah,
iPads.
so it's
Yeah, we
doing
get
that,
it. We get
CT urogram every, whatever, let's just say at 2 years. It's a lot. It's a lot of scans over time. So you space it out. I do. I space it out, and I'm trying to think, if I've found one incidentally. I think I have one or two, but yeah.
And can you guys talk about the risk of seeding by doing all of this scoping?
I'll address that in a second. I think to answer, I'm lucky. I work in a center where we're so subspecialized. I got my, bladder cancer experts. We do see those where they're caught on survey, but we also have high volume of disease.
Yeah.
But I think what might help, and I don't know if you're doing this already, but to risk stratify them. And if it's someone with low-grade disease, I mean, of course it's possible, but they fit in a very low-risk criteria. If it's someone, on the other hand, with a long-standing history of BCG treatments and non-muscle invasive CIS bladder cancer, they're going to be a higher risk. And so, you can always triage it, a little bit more that way.
In low-grade disease, I don't do routine, upper tract screening.
Now,
It's
if you
just
start
a
seeing
lot.
tumors around the orifice, obviously, or you see tumor poking out of the orifice, then you want to start thinking about it. But
Low-grade
otherwise,
bladder
yeah,
disease.
those patients, you don't necessarily need to be screening their upper tract, or do it, minimally, right? In terms of your question, I can tell you what we have really good data for, and then I'll talk about data that I disagree with, and then and there may not be agreement on that disagreement. There is data that suggests that the more manipulation we do of the upper tract tumor, the more we risk seeding the bladder. And there's some great studies, actually Mayo Clinic and I think Memorial Sloan Kettering have separate papers looking at this, and it's almost like a dose response curve. Whereas patients who got no ureteroscopy versus those who had ureteroscopy but no biopsy versus those who had ureteroscopy with biopsy, you literally see like gradations of increase in seeding. And so it's been interesting to see people's reaction to that, because the immediate reaction is, oh my gosh, we should stop ureteroscoping, which is exactly the opposite of what a lot of us have been trying to, teach, because what we're doing is trying to be more precise about our approach to this disease and risk stratifying, and that requires ureteroscopic management. So how do we consolidate all that information? And so for many of us, we look at the bladder cancer data with prevention with intravesical chemotherapy. So I basically give intravesical chemo to every single patient that I ureteroscope. I mean, the concept is the same. In fact, it makes more sense, because with a TURBT, we have great data for it. And in that case, you're giving it for prevention in that local area. And it's not just to prevent the implantation, but maybe if there's any microscopic, endothelial tumor, questionably if it's going to be effective for that. For upper tract disease, you're purely looking at implantation of floating around cells. So to me, it makes even more sense to give it. People are like, well, there's no data. Well, true. We don't have any direct level 1 data, but there's circumstantial evidence for me is overwhelming.
There's an ECOG trial right now looking at that question.
As there should be.
Yeah.
Great, yeah. Do you disagree with that? Or
No,
what
I
do you
don't
think?
disagree. I mean, and one of my colleagues, Steve Chang, is doing that routinely as well.
Yeah.
And it's compelling.
And
And you give it in the bladder.
I give it in the bladder,
Yeah.
every single, in the recovery room, after ureteroscopy. Even if all I've done is looked at the tumor, I'll give, because again, the side effect profile, especially with gemcitabine, I've given it hundreds of times. I have yet to see a patient have a major issue as a result of it. It's very safe.
I've had one patient from one dose of gemcitabine lose hair.
Okay.
One patient.
Okay. All right.
So,
You still
but-
give it.
Of course.
Okay. Yeah.
But what about patient that you're planning for Jelmyto? Do you still give it?
Yeah, I still
Yeah.
give it.
Yeah.
I still give it. Yeah, my threshold to give is exceedingly low.
Yeah.
Again, the side effect profile is so low.
Yeah.
The cost of gemcitabine is actually much lower than mitomycin as well. And so, in terms of healthcare dollars, I don't feel guilty at all
Yeah,
about it.
I agree.
Now, can I tell you what percentage reduction in risk I'm gaining from that? I can't. I don't have that objective data. That's what we don't have, right? I can't really give you an objective number. But there's no question, with the overwhelming circumstantial data, that the risk benefit is there in the favor of using it. So that's my long-winded answer to your question. Now, where it gets controversial is, resecting the orifice. People say that if you stent during TURBT, you're seeding the upper tract. I think a lot of that is hokey data. We don't go around stenting people willy-nilly. There's a reason we're stenting them.
I agree.
And that underlying reason you're stenting them is probably what's predisposing to upper tract disease. Now, could it be that we're seeding in some cases? It's possible, yes. If you're dragging the stent through tumor, potentially that could be happening. But
Ideally, you're placing the stent after the tumor's gone from the bladder.
you what now?
Ideally, you're placing the stent
Ideally
after the tumor is gone from the bladder.
Yeah.
Yeah.
So but it's controversial, and I just don't think it's very good data, and people are just taking it at very superficial face value without necessarily thinking through. But others may disagree with that opinion. Okay, to wrap things up, for low volume, low grade upper tract cancer, you can consider either doing the endoscopic ablation that you're doing or doing a subtotal, and then giving the mitomycin hydrogel as induction, or to give it as limited doses as adjuvant. Have a very low threshold to give patient a treatment holiday if they're in any way either stricture or they're having a difficult time with it. Again, it's low volume, low grade disease. You're not in a particular rush to get things done quickly. Now, we didn't really talk about this, but if it's high, you actually did, Adam, which was great in terms of, what do you do with a big, bulky, low grade tumor? It's not necessarily wrong to do a nephroureterectomy in that case. You don't want to, run into the trap of kidney preservation being so overwhelming that then we're risking the potential for heterogeneous disease, high-grade disease being present, or seeding the bladder from extensive endoscopic management for something that, maybe not be easily treated.
And I'll just comment, look at your images. I mean, look at the images. I've had patients referred in for low-grade disease, referred for consideration of gel-mito, and they've got, evidence of what looks suspicious for invasion on their imaging, on their cross-sectional imaging. So just
Right.
be cognizant of
Very
that.
good. Yeah, because
Yeah.
our radiology colleagues may not necessarily be in the mindset of looking for that.
Yeah.
And they're not considering the nuances that you are necessarily. So perioperative systemic therapy works effectively. We have very good data in that regard. The dilemma really is, how do we sequence it? Do we give it before? Do we give it after? Which patients do we give it to? And so what we've hoped to do here is to try to introduce some more precision into what we do by assessing the risk before surgery, and before surgery also estimating the kidney function after nephroureterectomy. And so we've talked about these different scenarios, and where the answer may not be clear, and the patient has to be involved in that conversation, where it is not. Of course, they're involved always, but the strength of our recommendation should be based on the strength of the evidence we have. And if it's not that strong, then the patient should be involved, of course. We didn't really go over the lymph node dissection too much. You do have that in your syllabus, but many of us do consider lymphadenectomy for high-risk disease, and it's template-based dissection based on the location of the primary tumor. And then for Lynch syndrome, we've introduced this idea of primary treatment with pembrolizumab, and it's an indication that we're increasingly exploring. Dr. Feldman asked a great question, is what is the data for upper tract disease, Lynch-related upper tract disease? Listen, I think that's a great project that we all need to think about looking at, with some of the multi-institutional groups that we're involved in. I think that's prime data to look at. So again, we've talked about the first bullet, assessing kidney function beforehand, using objective data. Prevention is always better, and the intravesicular chemotherapy data is very compelling. The biggest problem, I think, especially to give it at the time of surgery, definitely is that initial inertia of establishing a protocol and an SOP, and having the nursing team and the OR staff being comfortable handling chemotherapy and how you're going to do it and how it's going to get there and all these things. But once that pain of establishing it is worked out, it actually, I think in our combined opinion is that it's really better for the patient and also for workflow once it's established and giving it at the time of surgery. Always remember to ask about a family history beyond just urologic, but family history of colon cancer and endometrial cancer, particularly for this disease. And that summarizes it. Thank you all so much for your attention. We're happy to take any questions if you'd like.